So yes, I do have to head back to my clinic this afternoon, unfortunately. And hopefully the talk and some of the descriptions of the services I provided can make us all think, when can we possibly get the Hep C treatment underway sooner than we might have thought was possible otherwise. I'll close there. Thank the organizers once again, and I'm happy to take any questions. Okay.
Oh, he is tall, isn't he? Okay. Thank you, Dr. Fraser. One of the things I would like to reiterate is when we're thinking about the consensus guidelines, back in 2004, patients from vulnerable populations were not even considered in the guidelines. It was mentioned, but not really considered. The consensus guidelines in 2007 have made reference that all patients that are diagnosed with hepatitis C should be assessed for treatment, and that definitely does improve our vulnerable populations. I as well work with direct observed therapy in my region, and I have had incredible successes that really truly warm the heart. So I'll open the floor to questions.
Yes, this is going to sound so far left field, but I like to think out of the box. I look at both extremes and I find my comfort zone. You were identifying criteria for selecting people for treatment, drug users and a variety of other things. And I'm a strong believer in the power of the mind. And there's people with addictions that can overcome them through medication and through hypnosis. I'm wondering if there's been any kind of consensus that there might be some benefit to subjecting people to hypnosis to help overcome some of the obstacles that they have, if that's something that could be considered, because there's people that I know of who tried to quit smoking for years, couldn't do it, got hypnotized once, next thing you know, they're good to go. Is that something that, as far off left field as it is, it warrants some kind of consideration?
Thanks for the question. You know, addiction, I think, is a mysterious condition. What is the mix of psychological, genetic, substrate, plus the drug that ends up harming people's lives? Why does it occur? We can't predict it. It cuts across all social groups, cuts across all economic strata of society. And I think we're still looking for advancement in that area of medicine very much. Hypnosis, I don't think, offers a great deal. I think the issue is that one has to be consciously engaged in a process of change. And so to that end, the only thing that I've seen work, which is along those lines, is something like structured relaxation through meditation, insight-oriented therapies that give people a chance to reflect and plan, and then achieve a team around them that will allow them to make steps forward.
Thank you. That was a great presentation. I'm wondering if you, all of the cases that you described and that Fran has talked about, and that a lot of us in this room know about what works in terms of creating supportive healthcare environments that will engage folks. There are some key things within that, and that is that there are healthcare providers who get that. And then it can work brilliantly. So the question is, do you know what any work that's being done for physicians, the general practitioners around the province to work within their own clinics to start to, because the reality is, I think, is that, and maybe that's actually not a reality, but there are going to be Kool-Aids likely in smaller, more remote communities. So I guess, sorry, it's a bit of a long way to get there, but is there movement within the medical profession to integrate the principles of how this can work within regular practice? Is that happening at a professional level in terms of training in universities or continuous training for physicians?
That's a good question. I think that it comes a bit back to what Dr. Myers was saying in his presentation. With these conditions, we need to develop centers at a regional level which feel they have the capacity to treat successfully people who are in front of them. So, for example, on the island, I know Campbell River's got a very good program, France program in Nanaimo. And those are instances where an interdisciplinary team has come up. So by necessity of HepC care is by definition a partnership between physician, nurse, pharmacy, outreach worker, that sort of thing. I don't think there's enough structured training of physicians how to work in that environment. We're a training site for many residents and students, but I don't think it's a requirement going into practice that you set up in that way. But I think as more students and residents get involved, the benefits of providing care in that setting, I think many are finding it quite appealing. But I think it comes back to fostering structure of creating these centers where the treatment will occur and roll out.
Maybe as well I can make a short comment on that. In the fact that what we're looking at is hepatitis C and addictions under the chronic disease management model. And I think there's a paradigm shift within the health authorities in the creation of integrated health networks to create one-stop shopping.
In response to an earlier question, I think CASL has certainly looked at a lot of the nutritional alternative therapies and found support for that. But the post-traumatic stress disorder issue, I think a lot of those symptoms are the same thing a lot of people with hepatitis C have. And maybe this is a bit hysterical, or like, is there a relationship between post-traumatic stress, people who are prone to addiction, either like more vulnerable to daily stress in how they recover or how sick they get? If that's a clear enough question for you.
Yeah, sure, there's something in there that, in terms of the psychological, genetic fragility index for that person, and that definitely adds together, I think, to make them a higher risk individual. And that's why, engaging frequently in therapy is an excellent way to get insight and make steps forward.
Thank you.
Hi, I know this is probably a really silly question, but anyway, I'm going to ask it. You at the end there, you showed a slide about one of the key barrier would be the number of pills, perhaps, that have to be taken every day with dietary regimes to go along with it. Where does the interaction with the drug companies come in on this? In other words, you've identified that, we've just seen it on your slide. Who works with the drug companies to say, can you make this a one-pill regime? How does that happen, and how close are the drug companies to making that sort of thing a reality? Because I don't have Hep C myself, but it seems to me a very daunting thing and a real barrier, just psychologically.
Yeah, good question, and that's a really important thing, to spend time with people. We talk about that a lot with HIV, and I think we will be talking about it with hepatitis C. How do you feel when you look at those pills and they're some weird orange or purple color? What does it make you feel? What's your reaction to it? And we really try and get people taking the stance with themselves that when they ingest those pills, they are taking a very powerful step for improving their lives. And avoiding the idea that this is a foreign thing that they're ingesting, that's a difficult task. But you can take it as a given that the pharmaceutical industry is really fast-tracking all possible attempts to have robust, once-a-day regimens available as quickly as possible. When there are a high pill burden, it's really what they were able to attain in the lab of cramming that molecule into a reasonable-sized tablet. So there is a huge drive to do this, and because they're chemists and pharmacists want to make the treatment simple and successful. They're people as well, and they know that if they can get this simpler, it's going to be much better overall. Having said that, I had patients who were taking 3 times a day protease inhibitors for HIV back in the day, and they made it work. So I think we have to really, this is what's here now. This is going to change and improve and save a lot of lives, and I think that our job as clinicians is to identify whatever barriers that individual has, about those 12 or 6 pills a day, and really try and shape their thoughts about it, really try and reshape it and make it work. And really, this is a short-term thing. The other thing my HIV patients are doing, they're doing this for 4 or 5 years continuously, 6 in the morning, 2 in the afternoon, 10 at night. And that one had to be fasting, actually, that particular protease inhibitor, so it was a really challenging one. So the fact that we're setting this up for a short period of time, I think, is key, and you know, contrasting other areas, but it is definitely all headed that way.
I definitely don't feel that drug use should be hindered being able to get on the hepatitis C treatment. I know that with the introduction of protease inhibitors, it's my understanding that it does have a lot more serious interactions with some medications, including street drugs. I believe, in fact, that combined with crystal meth, protease inhibitors can be deadly, and I think it's a long time since I've read that, so correct me if I'm wrong. But I'm just wondering if perhaps there should be more talk with the patient around what types of drugs they're using and what specific interactions they could have with the protease inhibitors that are going to be included in the treatment.
Oh, sure, very much. That's a key part of the discussion in the education phase, contemplating treatment through the support group, identifying exactly what's going on. I think also making clear, making the person very comfortable telling us exactly what they're using, what their preferences are, what they feel their capacity for change is, their interest in doing any kind of reduction or treatment is. That's a key part of the initial discussion. And there will be studies done with street drugs at some point. Those are, again, going back to my history of HIV, methadone has been studied, so opiate substitution has been well studied, and the interaction is not significant at this point. It's going to be studied in larger sets, and if the bigger sets show a significant interaction, that will guide therapy. We've dealt with that possibility with HIV, where there are some key interactions where the methadone dose would change for someone on therapy. So there may yet come out, certainly people who misuse the benzodiazepine pills, if they're getting those from the street or without their doctor's prescription, there can be some interactions, and the midazolam interaction that Dr. Myers highlighted could potentially occur with other pills in that class. Crystal meth, I think, hasn't been formally studied at a bigger level.
I think it was ecstasy. Thinking back, I think it was ecstasy that I read about in that case.
Yeah, that would be more at a case report level, and I think that will be followed up. And as soon as something like that is marked with a case report, it's assessed more clearly. But again, we would really look at trying to work with people to really have the really unsafe things right off the list as much as possible before treatment.
Okay. Any other questions? Okay. One of the things that we do find with patients that are going on to treatment, patients that embark on, regardless whether it was standard of care therapy or even triple therapy, we've really, as nurses, have never worked with a more incredible group of patients that are willing to do anything to get rid of this virus. And it really doesn't seem, with the patients that we have treated, a huge problem with the increase in the number of pills that they need to take. So, we've got a couple of minutes. They're just setting up for lunch. They're bringing in our box lunches. We've got about 2 or 3 minutes. I'm wondering if there's any other questions that anybody has for either Dr. Krajden or for Dr. Myers. Would they nicely be able to answer us? There. So. Yeah, I'll grab another chair.
Yeah, I was just wondering,
Okay.
with the development of the two inhibitors there, and both drugs seem to connect, but one seems to have more serious side effects than the other, and in being prescribed one or the other, what's the scenario if you get to the point where you're going to get the treatment, the health authority will say, well, you have to have tenofovir because it's cheaper, and your skin's going to fall off and your butt's going to fall off. But we're going to give you that one because we can't afford the other one, or is one drug going to supersede the other in popularity, or be discontinued because it has more side effects, or what's the scenario there, what's likely to happen there?
There's a lot of issues in that question. Most likely, these drugs are going to be approved in a similar way. You know, BC Pharmacare is going to decide to approve one or both or none. So then it's going to come down to an individual discussion with the patient. The overall effectiveness is similar between these medications. There's never been a head-to-head comparison to prove that one's better than the other. So I think really it comes up to a decision between the patient and the doctor. There are some differences in terms of side effects. The anemia seems to affect both products. The rash is more so with the tilaprovir. The abnormal taste is more so with the boceprevir. I think you have to discuss it with the patient. Some patients say, I don't want to get a rash. I've heard about it, I don't want that, so they may favor one product or the other. Really depends.
You're saying that the rash and the angle problem seem to be with the tilaprovir.
Certainly, I mean, some patients are certainly afraid of that. You mentioned those potential side effects.
Well, given a choice, I mean, which one, if the doctor says, which one do you want, is it going to happen that, is that going to be it, or are they going to say, well, we're going with this, if that's going to hurt, but it's cheaper, what's going to happen?
I think there's multiple things you need to consider. The other thing is we've heard about there's pill burden, that's a different amount of pills you need to take. Another difference is the right duration that you need to take, the different medications, the different regimens. One you take for 12 weeks, that you may take for longer. So these are all things that come into the decision making. And you can't give a blanket recommendation really, I think, is to use one product or the other.
The one will supersede the other if it's more successful, basically. If it's more appealing and more successful, generally it
Yeah, I mean, we'll have to see what happens. I don't have the crystal ball out, but we'll see. We'll see what happens.
Can I add to that? I was on tilaprovir. I was aware of the rash possibility. I did not get the rash, and not everyone on the drug gets the rash. So I was willing to deal with the rash if it happened. It never happened. There you go.
Any other questions? Oh, okay.
Yes, I was just wondering, is the interaction with marijuana, when you get a test done on that?
Not that I'm aware of.
Maybe I can interject. I was asked to attend hepatitis global nurses meeting in Dublin, Ireland before Christmas. And we were discussing the use of marijuana with our patients. And I said, in some of my population, approximately 80% use marijuana. At the end of the day, it was noted that 80% of Canada uses marijuana. So that's my claim to fame. So,
How can we expect the triple therapy to be standard of care for genotype 1?
I think in my mind it is standard of care now. Now we just need to get it reimbursed.
Okay, so it's already, if somebody is seeking treatment for genotype 1 right now, it is the triple therapy at this very point?
That would be my optimal choice of treatment, yeah, if I can get it. Yeah, I mean, the recommendations from the Canadian Association for the Study of the Liver is that this is now the standard of care for genotype 1 patients. Some people suggest that maybe you can get away with just double therapy if somebody has a very rapid decline in their hepatitis C RNA. But I think in most people would favor using triple therapy.
I was just going to add to that I had a strange interaction. The first time in my career where someone came in very had to start Hep C treatment within the last month, and I put on the brakes, and I said, please wait a couple months till we have the third agent reimbursed. And this person became quite upset about that, thought that we were putting the brakes on their access to treatment. I said, well, look at the numbers of your chance of cure. This person was a 1. And so I think the key is everyone in this room who's involved in this issue, make sure you watch closely the pharmacare decision. Stay in touch with HepCBC, and if it doesn't go well or to the organization's satisfaction, get your voice heard. There may need to be that level. Again, the HIV deja vu effect here, that a lot of what we have with HIV now came about because of citizen action in a democratic society. So that may not be beyond the realm of what's needed in this issue, I think.
At the present time, the only way they were actually able to access triple therapy is if we can get standard of care through the provincial government covered if they've never been previously treated, as well as triple therapy with the either Incivek or Victrellis through third-party coverage. That's it at this point in time. Okay, any other questions? And I think, oh, over here.
I just have a quick question for Dr. Krajden, just in regards to the HepCBCRs.
I knew that was coming.
Sorry, it's a selfish question. So just in response to the response-guided therapies, we're wondering whether or not we're going to have a quicker turnaround time with PCRs that are decision makers during treatment. Right now, we're waiting exactly 3 weeks.
I'm aware of that. We are moving to all quantitative testing, and we are having discussions with PharmaCare to try and see if that can be part of the package. It's like everything else, it's a resource issue, but there's no reason that you can't turn around the test. It takes essentially 2 days to do within 7 days. So it's all part of the pieces that need to be put into place to provide proper care.
I think I want to ask this on the stigma of hepatitis C as it relates to hepatitis B and A. And I wondered if there would be a value or how difficult it would be to reclassify the hepatitis C virus.
What is interesting is that Hep C has stigma for a variety of reasons. Hep B has a similar stigma. We just don't realize it as much. So in China, Southeast Asia, Hep B is very stigmatized, and people in the population are discriminated against. I think the real challenge, and I think that's some of your discussions earlier with your discussions about what a doctor should be doing or a healthcare provider, is that there's the stigma that the person feels because they're affected. And then there's the stigma that is overlaid by the healthcare provider who basically isn't appropriate. And so we somehow have to get rid of both of those issues. And it's also true for HIV.